Welcome everybody. Thank you very much to be here today with us in this wonderful session from Philips at the PCR London Valve 2020. It's a great honor for us, the Bordeaux team, to be involved this year in the PCR London Valve, and it's a big day for me because I am today with two big guests. So thank you very much, Rebecca Hahn and Stephan from Bardeleben, to be with us today and share this session. So if you agree, we can start the movie, and then we will have a discussion after the first part, after the TAVI, and then we will have some minutes to discuss after the Microclip. See you after the first part.
Hello everybody, thank you for the invitation from Philips to this symposium at the EPCR London Valve 2020. We are very happy here in Bordeaux to welcome you in this hybrid room to perform a procedure which will combine two procedures. First one, we will implant it at TAVI, and then we will treat a mitral leak with a mitral clip on the same patient or during the same procedure. So here in Bordeaux, we have Philips Azorion Flex Arm hybrid room. And all the team today with us will be Thomas Modin, our surgeon, Stephan Lafitte for the echo, Jacques Latrabe at the head for anesthesiology, and of course all our wonderful nurse team. So next slide, please. So we are today the 14th of October, and as I explained, all the procedures are performed by a combo of a surgeon and interventional cardiologist in this dedicated hybrid room, which is located in the surgical department. Good point for this new hybrid room is several axes of rotation of the C-arm, which allows you to work in a different position. So the case today, we have here a wonderful gentleman of 89 years old. He's a very good shape man. He was admitted 2 weeks ago in intensive care unit for acute pulmonary edema, and at echo we find the reason for this dyspnea. It was a grade 4 mitral leak due to a rupture of chordae on the P2 and P3 prolapse, as you will be able to see. But also he has an aortic valve stenosis. The check was very good, no kidney disease. On coronary angiogram it was a little bit different. Next slide. Because if the right coronary artery was wonderful, the left one showed a very severe stenosis on the LAD. So next slide, we had staff in a heart valve team, and we decided, because of the age of course, to stay with percutaneous treatments only. So we decided to perform before all a coronary angioplasty, and then to propose to the patient a TAVI and Microclip procedure. About when to do that, we decided to do the TAVI and the Microclip in the same procedure to be more comfortable for the patient and to reduce the length of stay. Next slide. This is a result of the LAD stenting, which was very simple with very good result. Next slide. And the aim today is to show you how we use Philips tool, because we have to keep in mind that our goal today is to have a good access to the coronary ostia for this man, and we will show you how we use the interventional tool to assess a very good commissural alignment. The fusion between echo and X-ray will allow us to have a very securely deployment of the mitral clip for the second part of the procedure. Next slide. Just this explanation to show you how is a core valve. The core valve have two pallets and 2-3 posts. So we want to deploy the anterior pallets with a C of core valve in the anterior part of the patient, just between the right and the left coronary artery, because this pallet is just in front of a post, and the other pallet without the C have to be positioned posteriorly, because we don't want to have a post of the stent just before the coronary ostia. And now we will show you how we can do the planification of the procedure for TAVR. As you can see, we are scrubbed and we can control all the procedure from our tablets here. Here we have access to the vessel navigator tool. So we will select the left side, and then we will see if there is no too much tortuosities and if the diameter of the vessel is enough. So as you can see here, there is absolutely no problem with the use of this vessel. Here the computer is opening the case and show you immediately how we locate the 3 yellow dots at the bottom of each leaflets. 2 other dots are positioned, one at the left coronary artery, which is the blue one, and one at the right coronary artery ostium, which is the red one. Okay, so we just have to check if the dots are well positioned by the computer, and then it will calculate immediately different things. Of course, first of all, the annulus. Here we are at around 24 millimeter of diameter, so we will choose a core valve 29 for this man. We can see if LVOT is bigger or not. Here it's not bigger, so there is a little bit of myocardial hypertrophy, so core valve is probably a good choice for him. And we can see if there is no problem with the high of the coronary implantation. So the right one is at 16 millimeter and the left one 14 millimeter. So here you can see there is not a big amount of calcium, and there is absolutely no calcium in the LVOT. So we could have very good results with a core valve. You can plan the different C-arm orientation, but what we can do is a fusion with the fluoroscopy, and it will help us to choose the good C-arm orientation for the deployment of the valve, as we will show you. So before starting the procedure, Thomas inserted a sheath in the left radial artery and the left femoral artery, and one more in the right venous access for the Microclip in the second part of the procedure. So we can start. We use the interventional tool for fusioning the phantom of our CT with the X-ray. The machine suggests you 2 C-arm orientation. You don't have to use a lot of contrast, and by yourself at the table with your mouse you can adjust the 2 pictures, and it's very easy, very rapid to do, and then it will be very easy to go in cusp overlap view, just pushing a button. So we choose this view to deploy the valve. Here you see on the left on the screen the follow dot for the non-coronary leaflet, and on the right the 2 other yellow points which are overlapped for the other leaflets. In this C-arm orientation you cannot have any parallax problem, and what you see is the real depth of implantation of your prosthesis in the LVOT. Whatever the cranial caudal orientation, you can add to your C-arm. So when you are happy with the result, you can deliver the valve here back in LAO, and when the valve is completely deployed, you just have to do your check. Thank you everybody for this first part of the procedure. The TAVI is deployed and in place with a very good result, no leak as you can see. And what about coronary access? You know, it was a concern at the beginning of the procedure. So if we choose an orientation of the C-arm with the localization of the right coronary artery on the left on the screen and the left one on the right on the screen like this. You see that there is absolutely an overlap of your two pallets, and the pallet with the C is anterior and the other one is posterior. It means that the anterior pallet is strictly between the right and the left coronary artery, so the post of the bioprosthesis is strictly located between the coronary arteries, and there is no post in front of the ostia. What we can check with the interventional tool is in cusp overlap positioning. So in this positioning of the C arm, we have to check that the pallets are just one in anterior part and the other one in posterior part of the aorta. So it means again that there is no post of the bioprosthesis in front of the coronary ostia. So very good result, probably very good access to the right to the coronary arteries, no conduction disorders, and we can now go forward and look at the mitral leak. So thank you for this first part, and I will give the microphone to Stephan Lafitte, who will comment us the mitral disease, and then to Thomas for the procedure. Thank you.
So it was the first part of the procedure, an evolute, and with a concern about commissural alignment and use the cusp overlap to be more accurate about the depth of the implantation of the core valve in the LVOT. Rebecca, perhaps first, do you have the experience of such a patient treated by the TAVI and Microclip in the same procedure in your center?
No, we have not done it, but I do believe that we know certain patients will not have their mitral regurgitation reduced by the TAVR. So in some situations, you have high gradients in high left ventricular systolic pressures, which will exacerbate the mitral regurgitation. And in maybe 30% of functional disease, we may see a reduction in the amount of regurgitation. But that early on, it was pretty clear that we weren't going to see a huge reduction if there was degenerative disease or even a component of degenerative disease, and that those patients would continue to have issues. We do think that when we have mainly done them as sequential procedures, but when we do that, we do treat the aortic first, with the hopes that maybe it will reduce the mitral regurgitation, but frequently with degenerative disease, we're going back in and doing the Microclip.
Yeah, in this case, it was a primary mitral regurgitation. That's why it was not the same question, but of course for functional, it's a bit more different. Ralph, Stephan, do you have this experience of treating both valves in the same procedure, and do you use fusion in your daily practice?
Well, we use fusion in our daily practice, and I think you've shown it nicely how easy it is to depict the coronary status without even injecting any contrast. So once you have aligned your cusps, and we always need, for the height of the implant, we will need one contrast injection. So you nicely showed that actually fusion gets you rid of the need of additional contrast here. Fusion at the moment, as you've shown it with the heart navigator, still is not going along with the contraction of the heart. So we've seen that the height estimate, of course, still is limited. But what is nice is the rotation of the C-arm control, which is quite accurate, and you know actually where your cusps are. And this is much more precise than multiple injections of contrast. So I think this is a huge benefit of fusion imaging. And also everybody who has to learn the procedure really benefits from fusion. And we would only do a common procedures. We did such a common procedures over the last, I think, 2,000 TAVRs only once or twice. And this is only true, as Becky pointed out, if we have a primary disease with a chordal rupture and flail. In this situation, this won't get better through the TAVR, and then you can do it in one procedure. Most cases are functional disease in mitral, and as Becky pointed out, 30% may get better. And this is why I would say also here, 95% of the cases, I would do them staged, not combo. But a flail leaflet would be the only indication at our site to do a combo procedure as you put it in your case. So I think that's a wonderful indication, and this can be done. We would have perhaps not put in the TOE probe up front and done the first part conscious. We're moving also with mitral tricuspid slowly away from general anesthesia. It's slower than on TAVR, but I think this move will be accelerated with four-dimensional ICE in the future.
Thank you very much for these comments. Perhaps we can go forward and look how was the mitral valve and the mitral deployment.
Hi everyone, I'm Stephan. I'm very happy to be here with you to comment the Microclip procedure. For investigating this mitral valve, obviously by adding the color we have severe mitral regurgitation, which was appreciated previously by TTE. There is no doubt of the severity of the regurgitation, but now we have to go further in describing the lesion of this valve, and then from this bicommercial view I'm adding the explained view on the zone 2. In the middle of zone 2 you see the coaptation exists. By adding the color there is no major pizza in this area, and then I'm going a little bit further on zone 2. And now we can assess and evaluate the prolapse with chordal rupture, as you can see. Definitely the leak is coming from here with a huge pizza in this area. So next step is to assess mitral valve through 3D modality. We have here with the chordal rupture, and the prolapse seems to be not very big. Now we have to decide the strategy. So it could be a strategy with one clip. I think for an easy way of clipping, maybe the XT clip will be the one we would choose today. Now we're ready for the transseptal guidance. This guidance will be performed through a combined modality, imaging modality. What we have from the Philips system, and we have the Echo system, an EPIC, CVXI, and the Fusion, which is obtained with the Echo navigators. On the screen you can see some dots coming from the Fusion or the view. I have the Echo, which is superimposed on the X-ray. And obviously for Thomas it's very easy to look at this fusion imaging, and you see that the red dot is the area, fossovale or area, which should be the target, the best target for the punction. Okay, so Thomas, you find perfectly the area localized on the X-ray through the dot, the red dot. From now, we have to check the distance between this position, the catheter position, through the valve. We have already 4 centimeters. On this view, coming from 45 degrees and explain again, you can see that the tenting is perfect. So we're ready for the puncture. Okay, the punction is performed, the needle is out. We have the catheter inside the left atrium right now. On this screen, and now we're preparing the rest of the procedure by using the fusion, but already you can see that we have 3 dots on the X-ray image. These 3 dots corresponding to the passage of the catheter through the septum. The second one is the left appendage and the Concomitant ridge, and finally in orange probably the target of the Microclip, but we agree we have to assess secondly this dot and this objective. So another very interesting tool we have on the Echo Navigator is the Global Heart Fusion. So we do some acquisitions. The first acquisition is coming from 3D. The second is an X-ray acquisition. We change the flex arm position to an opposite position in order to have 2 dimensions in the X-ray acquisitions. Okay. The system is modeling the heart, and you see that there are some form, some model in the echo which represent the personalization modelized heart. It's quite okay here, so we can accept this model. We obtain the heart, and we can changing the structure we have on the screen, 3D or not, different plane, which can be and which will be very helpful for the next part of the clipping.
Okay, so we are now going to advance the guiding catheter through the transseptal puncture that we just realized. I just have to be careful. You see, we follow the dot, the marker that have been done thanks to the fusion between the echo and the fluoroscopy. So you can see that the fusion here is gonna help us identifying the marker not to miss, to keep tracking throughout the procedure. So Lionel is manipulating the clip, and I'll be manipulating the guiding catheter. So I'm giving a bit more anterior, you see. Again, the 3 dots is orienting us. Okay, so we pull. The more you advance in the left atrium, you try to pull a bit to give a better trajectory to your clip catheter. And Lionel is adding more medial now, you can see it, to approach the leaflets and themselves. So we are in the left atrium, we are away from the ridge, and we are getting closer to the valve, as you can see it here. So this is the 3D now echo. We switch to 3D echo. We're gonna check the axis. Again, we have to be sure that we are in the right alignment of the prolapsed, but also the diseased segments of the mitral valve. Okay. We're gonna use the fluoroscopy now. So we have aligned the Microclip, again, in the axis of the lesion of the leaflets, which are our target. And we check on the fluoro that the orientation will remain the same when we're gonna dive into the ventricle, because what happens sometimes it twists, and this will give you an additional landmark to be sure that you are still aligned in the position you have prepared and planned to achieve the clipping with. So you see, adding some colors, you see that the clip is in the middle of the jet, which is already a good sign. Okay, so we're gonna dive in the ventricle now, slowly. The clip is a bit closed when you dive in the ventricle, of course. It's opened again. We are pulling gently back to the annulus. You can see that the posterior mitral valve is started sitting nicely on this clip, partially open. We're gonna check that the anterior also is okay. The medial ladder are okay. The grippers are down now. We're happy with the position. You can see that the leaflet is already stable, and you can see the grippers are swinging with the leaflet's movement, which is a good sign. So we are grasping the anatomy. The clip is getting closed by Lionel. Okay, so once the clip is closed, we can evaluate the result. So of course, if there is any remaining leak, any remaining significant regurg, but also the amount of tissue of the leaflets which is grasped and captured by the clip. So one additional feature that helps you evaluating the quality of the clipping is that this, if you look at the 3D image here, both on P3 and A3, you have a triangular shape, which means that you have enough quantity of tissue, but also the quality of grasping, giving this triangular shape, which means that the anterior-posterior effect of clipping is met, which is a quality feature of the clipping. And the clipping will have a chance to be stable. Now we're going to evaluate the gradients, of course. And for 2 millimeter of gradient. So with this setting of very difficult anatomical lesion in an elderly patient, acutely compensated, I think we can consider that the result is very, very satisfactory. The planning of the procedure is very important, and the fusion and softwares that equipped with this hybrid room helps making the flow of the procedure easier, and I think everybody's happy with the result here. So the clip is completely released now. There's no attachment anymore, and you see the result is very good. Grade 1 mitral regurg in a patient which is very stable with a good hemodynamic. So this is a very good result. So thank you everybody for your attention. We are very happy here in Bordeaux to have been able to present this live recorded case for EPCR London Valve sponsored by Philips. We were happy to share with you these advances in cardiovascular therapies with this fantastic team. We hope that we will be able to see you soon physically, but also you're welcome in Bordeaux anytime to visit yourself this wonderful setting. Thank you very much.
That was beautiful. I am so impressed. I really can't believe how quickly you were able to accomplish that. So for me, just watching the use of the fusion and how so clearly beneficial it is to the patient, right, and to the procedure is amazing.
Yeah, sure. I don't know if you've seen, we were at the end of the procedure with 28 minutes of fluoroscopy, and the X-ray radiation was very low. And it was very comfortable for this patient to have both leaflets treated in the same time. So the big difference between TAVI and Microclip is, of course, the different way to see, to have visualization of our work. And I have to say, I'm like a kid when I see that I can see the valve with 3D, 2D, with fusion. Fusion in one plane, fusion on the volume. So of course we can do without, but what do you think, Rebecca? Probably it's essential today to use this kind of tools now.
Yeah, way back when we just had a biplane TEE probe, they gave us a 3D to test out, and I was saying, oh, we can get every single view with a biplane. What do you need the 3D? Why not? Why not have every single tool that you could possibly have? And how much easier is it for us to see the anatomy and to assure accuracy and precision and reduce the time for the procedure? That's what all of this, these new software and hardware packages do. They really make us much more certain about where we're going. You saw how quickly Thomas had gotten the transeptal puncture. I mean, that's just amazing. He knew exactly where to go. And I think the precision and the communication between the interventionalist and the imager is so much smoother when both parties can see exactly where they want to be.
I would say that even if you know your city, you are likely to use in your car a navigation system, even if you could do without. But the added value of having the navigation system, the speed control, and some other gimmicks with it, you'll never do without, even if you could drive alone with a classic car 30 years ago.
Can you tell us more about what is probably the future?
I think we're heading away from normal two-dimensional echocardiography, a black and white snowstorm 20 years ago or 30 years ago, towards more and more anatomy. And we're going to the surgical look and feel of a procedure without opening the chest. We see the most beautiful access here to a valve, and we see the coronary ostia leading from that. And look at the leaflets of an aortic valve moving. It gives you a torque and twist and a totally different appreciation. If we move to the next slide, we can see that we can go to the mitral. And this is an edge-to-edge device, actually a Pascal this time, so not an XTR. This is the new Pascal Ace. And if you can also start these images, please. And here you can see nicely how the clasps go down. And we can even see sutures in a sub-millimeter area. And look how fluent this change and the virtual shadow of an artificial light source shows you how we can grasp leaflets live in the body. And what is also nice is that if we go back one image, we can look through the devices and we can look through texture. Look at the aortic valve. The leaflets are continuous and you see them behind the aortic root. You can see the mitral leaflet behind a metal object. This is nitinol, but we can still look behind, and this will give us a whole new perspectives on the valves, on the treatment, on the rotation, on the efficacy. And this is just the first step. So Becky, what are your comments? This is just taken out from this week's interventions in Mainz. And you see we're using this on an everyday business.
Yeah, we've also just acquired the newest software package and just did two very complex tricuspid procedures. And the transparency mode that you showed is very beautiful with regurgitant lesions because you can actually see the Pisa below coming through the leaflets and, really the origin of the jet and its direction. It makes it much, much easier. I think that there are so many advancements on this new platform that we have as well on the 3D live multiplanar reconstruction, which we absolutely rely on these days. We can now rotate planes on each of the different two-dimensional images, so not just on three-dimensional, and there are now rotational controls on the panel so that you don't have to actually go onto the image and rotate your planes. It has made the procedures much faster, much more accurate. We can reorient all the images on 3D live multiplanar reconstruction as if they were just two-dimensional images, so that our communication with the interventionalists is flawless. We no longer have to explain, now this is anterior, this is posterior, this is septal, this is lateral. We have the regular images, the way they're used to seeing them, all up on the screen because we've just reoriented all four sectors. And so it's just amazing how much the software is making a difference in how rapidly we can communicate and get the devices in.
The pictures were fantastic, but I just wanted to share with you the last stand-in we performed with Thomas and Louis Labrousse in Bordeaux. because we used again different types of fusion. So perhaps we can see this very short movie of 1 minute about the tendine, and then we will probably have a lot of questions from the panel. If you agree, we will have to answer together. Okay. This very short movie, as you can see, the tendine on the same screen, the fluoro where the tendine is coming from the apex to the atrium, and to see the deployment of the valve in 3D and on the fusion at the same time, which is very comfortable for everybody. Here, the end of the deployment can be done with the X-plane. Again, fusion to be very confident with the positioning. Everybody is very quiet in the room. There is no rush, and the tendine can be delivered with a good result. Of course, we can have we can add some adjustment to be sure there is no paravalvular leak, and then we can do all our check with this very nice in-phase view of the tendine. So in this case, the result was pretty good, and the deployment by itself took something like 5 minutes. Of course, what is very long in this kind of procedure is the beginning and the end of the procedure with the surgical access, but with these different fusion tools and in this kind of hybrid room, it's very comfortable to be ready for the future with this all new TMVR for mitral and of course for tricuspid in the future. So in conclusion, I think all these tools are very interesting, and we probably are only at the beginning. So we can consider that we are very lucky to be involved in interventional cardiology during the years coming. Thank you, everybody. We will have some question now, and I want to thank you again to be here today with us.
Thank you. Yes.
Thank you.
Hello, Lionel. Again, congrats to your cases.
Hello, everybody. Hello, Ralph, Stephan. It's a pleasure to be here in direct live with you to be able to answer to some questions if there are some questions, of course. Hope you are doing well.
We're doing very well. Thanks again. I saw two questions actually in the live chat. One was about the position of the core valve in the first part of the double procedure. So somebody was asking whether this was low. There were, of course, some shifts with the fusion system. Perhaps you might want to comment on this.
Yeah, the fusion system is probably very interesting to help us to choose the best C-arm orientation to deploy the valve with a very accurate depth of the prosthesis in the LVOT control. But it's not the best way to avoid contrast and to be confident with a yellow dot to deploy the valve at the good depth. In fact, if you want to avoid completely parallax problem, you can be in cusp overlap, and with that, it's very simple to have a very good, accurate depth of implantation of your biprosthesis. And when you come back in LAO, it's very difficult to be sure that the depth of the prosthesis is at 2 or at 5 or at 0. The best way to be sure of the depth of the prosthesis is to be in RAO. So that's why it's very difficult to be sure that the depth was too low. In fact, we didn't have any conduction disorder for this patient. And in RAO, it was around 3 millimeters.
Okay. And the second question by the same person was about the situation. How often do you use fusion in your daily practice? So what is the main benefit? And of course, a lot of people will say that they can implant TAVR without these additional systems, and also Microclip can be done without. But you've also shown a Tendyne or other valve implants. So perhaps you can highlight from these three procedures and from your daily practice, what would be your major benefit on fusion techniques, Lionel?
Yeah, of course, you can do a lot of things without any fusion, but the two very important points with the fusions are, first of all, security. Because when you navigate in left atrium with a Microclip, or when you choose the good C-arm orientations for TAVR implantations, it's only because you want to have the better security and safety for your patient. And that's a very important point, because if I am a patient and if I know that I have two teams able to implant me a core valve with very good results, but one use fusion for high security results, and the other one don't use fusion, but has some good results. So I'm sure I will say, why doing without? And I will go in the center with fusion, even if the results are similar. So in my daily practice, I use it very easily, because it's not a lot of contrast and it's something around 30 seconds. If you plan your procedure with Up Navigator TAVR, you just need 30 seconds to do it, and usually the fellow is doing it on your right when you advance the prosthesis. So in terms of time, X-ray or contrast is exactly the same. So again, you can do it without, but if you can do it with, why don't do it?
Absolutely, and this was why I made the comparison with the navigation system in the car. Of course, it can be very helpful, it eases things, and I think it's also very nice for learning. And we're university hospitals, and we have, of course, implanters at different levels, and I think it's very easy for beginners to understand what they're doing. An expert like you, like Thomas, etc., we all know definitely about the anatomy in fluoroscopy, even if we don't see the valve in total. But I think if these additional helping instruments come into place, you understand, what does your RAO projection do with the cusps? What is your LAO projection? When do you have the cusps in line? When do you double the cusps? And when are your anterior, posterior, etc.? So I think that's a major advantage. And I think in the future, on mitral and tricuspid replacement and all areas where we don't have tubular vascular structures to come into the implant, this will become more and more important. And so you should train it before.
Sure.
Great. I think Becky has in the background also answered some question in the chat. And do you want to make some closing remarks, Lionel?
So I can't see the chat. So I probably have to click here.
There's a remark from Thomas Bodin on the depth to avoid the risk of a pop out. The depth of the devices are being controlled, so the pop-up risk would be less. Thomas Modin was just from your center, was just adding an additional comment.
Yeah, we all know that pop-up is around 4% in all the studies with Evolute or core valves. So usually because the first level of the insertion of the prosthesis was too high. So again, if you avoid parallax problem with RAO, it will be more comfortable. So till we use the RAO to deploy the valve, we don't have any pop-up. And it was a very good learning from the Midas study, where they explained that you can put the valve higher without any pop-up when you use RAO, and you can avoid a lot of pacemaker implantation like this. You're just more accurate, and it's very important. And the thing what we had which we had in Bordeaux, is the measurement, the assessment of the membranous septum. You don't have to be very, very high if the membranous septum is length. You can be at 3 or 4 millimeters if the membranous septum is at 6. So you're very comfortable when you know that.
Do you want to close? We have 10 seconds left. So I think wonderful session.
Thank you everybody again for this wonderful session, and of course Philips for their collaboration.
Thank you. Bye.
Thank you. Have a good night. Bye-bye.